Okay, so welcome everyone to the EM PoCUS UK monthly online educational session. My name is Michael Trower, emergency physician from St. Thomas's in London. So we have two fantastic speakers today. Shortly, Mehrad, the ultrasound lead at St. George's Hospital, will kick us off with some of his musings on the eFAST exam. And then Ehsan, ST7 at King's, will present a case-based discussion on the role of PoCUS in pulmonary embolism. But before we get into the presentations, I just wanted to briefly give you a little tour of the Slack platform that we're using for this group, because it may not be familiar to all of you. So I'll just share my screen and give you a quick tour. Hopefully you can all see this. So yeah, this is the group. Hopefully you're all in the group already. If not, I'll post the invite link into the Teams chat so you can join. I'll just point out just the main things to know. So if you click on EM PoCUS on the top left, this is the group. And if you go to invite people, you can either invite to an email address or you can just copy the invite link. And then you can just paste that anywhere into WhatsApp or anywhere, and you can invite any colleagues who you think would benefit from being in the group. In the top right, this is your own profile, so you can edit your profile, but also you can change your preferences. So it's actually quite sophisticated. You can choose like when you want to be notified, what you want to be notified about. So it's much better than just like a big WhatsApp group where you get bombarded with alerts all the time. And then these are the channels. So you can also choose what channels you're interested in. If you go to More and then Channel Browser, this shows you all the channels that exist, and you can choose which ones you want to join and which ones you want to leave, depending on what you're interested in. So General is the main one where everyone is a member, but then there's also introductions, so you can tell us a bit about yourself and connect with people nearby or with similar interests. Monthly online teaching is where we put the links to the teaching, but also the recordings for the previous month's teaching. And there's various other threads depending on what you're interested in. So if you're struggling to get your system onto PACS, there's a forum about that. There's one about serratus anterior block where Ehsan's kindly shared his guideline from his trauma center. Sharing images is just for interesting cases. The echo chamber is all about echo. So yeah, training accreditation. So whatever you're interested in, and feel free to create your own channels and contribute to it. The whole idea is it's a sort of a wiki sort of style, non-hierarchical group where everyone can just share and learn from each other. And yet you can also send messages directly to each other. So that's a quick tour of the Slack group. As I said, I'll just post the invite link into the chat now. So if you're not already in the group, you can join it there, but also feel free to share that invite amongst your departments. Okay, so without further ado, I'll introduce Mehrad Ramazany from St. George's to talk to us about eFAST. Thanks, Mehrad.
Hello, I'm Mehrad. I'm just trying to just confirm that, Michael, can you do the admitting? I'm just trying to do, and if can I ask if you're not, I'm getting a lot of feedback in here. If you're not talking, can you please mute yourself? Oh, lovely. And I'm not going to necessarily talk about, can everyone see the screen?
Yep, we can see.
Okay, perfect. And I just admitted the last person. I'm just doing it to a screen thing because of how ridiculous the IT system at George's is. So I should have said that it's been recorded now. Okay, I'm not going to talk about how to do eFAST. The people are way better at doing eFAST than I am. But I'm just going to do just a proposal about. All right. I've got a question, whether the eFAST slows you down or not. And we're going to very quickly talk about how to do it and a case presentation and some lessons learned. I'm Mehrad. You can find me on Twitter at NotSoEmergency. and I'm a consultant in emergency medicine at St George's Hospital, London, and I'm the ultrasound lead here, or good or bad. A bit of a disclaimer and conflict of interest. This is one of my happiest moments in life after getting married and having a child. So I'm very biased about using ultrasound, and I pretty much use ultrasound in anything, for anything and everything. So if I praise eFAST, that's could probably unbiased, but if I say bad things about it, just bear that in mind. Just a big thing about, I'm getting still getting some feedback. I hope that doesn't affect the quality of the recording. All right, so FAST initially was designed in 1996. I think, yeah, that's good now. FAST was designed in 1996, or proposed the protocol. It's only a 3-view to actually rule out intra-abdominal free fluid in trauma patients. And just moving forward, in 2004, it kind of got developed as a current protocol that it's being used. It kind of says a lot that still we are in 2021, and many of us, as in like many departments in the UK, are still struggling to do a good eFAST. We might still need to push ourselves to just, we're quite behind compared to the rest of the world. The important thing to mention for me is it's a binary exam. It's either there is or there is not. And don't look at the assessing the hydronephrosis. Don't get distracted. You're doing there's a reason for you doing that scan, which is, do you see free fluid or not? It is very specific. It's not sensitive. And that's applicable to pediatric population as well, but that's not the point that we're talking today. And one of the things that really annoys me is that when someone comes and tells you, oh, can you come and do a fast gallbladder scan, or can you do like a fast AAA assessment? FAST is focused assessment of sonography with sonography in trauma. So terminology is quite important for me, but that's me. I don't know about the rest of you. All right, so I'm going to talk about a case at 11:30 at night. That's when we normally hand over in George's to the night consultant. There was a 52-year-old patient who was brought in by HEMS as code red trauma. Basically, he was run over by a car, and he was intubated by HEMS at scene, and he had bilateral thoracostomies done because they thought it could be something, tension pneumothoraces. He had a blood pressure of 80/40. He had blood started by HEMS transfusion, and he basically came to us. He was intubated. He was ventilating actually okay. His blood pressure was at this point about 80/40, and heart rate of 110. He was intubated, obviously, and the pupils were sluggish, but there was no discrepancy in the size of the pupils. So important findings on primary survey was you could see the tire mark on his chest going all to from the belly to the chest, and he obviously had bilateral thoracostomies. Putting two fingers in his chest, the lungs were expanding quite well, and there was nothing hosing out of his chest, and there was no obvious long bone injury, no open wound. So basically, we were having a blunt trauma patient who had some stuff in his chest which were iatrogenic. All right, so the next question is, what are you going to do now for a patient who is code red trauma? You've started your management. Are you going to do ultrasound? Are you going to do CT? Or you want to do direct to theatre, general or cardiothoracic? I think the days of going to direct to theatre is pretty much over. And if you wanted to directly go to theatre, whether you want a general surgery or cardiothoracic these days, like you have to find what's happening exactly. CT, it's quite ballsy to actually take this patient CT because obviously he is code red, and against pouring blood into him, his blood pressure is 80. And ultrasound. So that would be, obviously, given the fact that this webinar is about ultrasound, that's the right answer. I'm not going to bore you about this. Just use your about how to do it. It's a obviously low frequency curvilinear probe, and this is taken from the model is taken from the Arkham learning website. You start with right upper quadrant, left upper quadrant, and 2 views from the pelvis, transfers and longitudinal, and then you get your subcostal, and then this is where it becomes the eFAST, where you add the bilateral kind of apical lungs to assess for pneumothoraces. And again, I'm not going to talk about how we're going to do that. You all know better than me how to do it. But my question is, how easy is to do it in a patient who is a code red? And bear in mind, you are like when you are doing a code red eFAST exam, you have got one anaesthetist, you've got 2 A&E registrars, 2 A&E consultants, and possibly an orthopedic and a general surgeon around. And I know these days with all of these new tiny little handheld devices, it's easier. But bear in mind that you just in terms of the setup, that how painful it could be to actually park a big sonosite export next to a patient and trying to do it while someone is trying to put an art line in or someone is trying to prime to Belmont. The reason I said that, just going back, is just because actually you don't be unhappy with the fact that sometimes you can't get the best image possible because you have got less than. There has been literature showing that you kind of can do an eFAST less than 5 minutes, ideally within 3 minutes, and don't be put off if you can't get good images. The whole point is trying to find a big abnormality if you can. This specific patient, like the images, unfortunately, I couldn't get all of them. So I've got the good images, but I've added some other images just for fun. So this is the right upper quadrant of not the same patient, but it pretty much looked the same. And we can see the Morrison's pouch in here, which was okay. And so there was no anechoic or hypoechoic fluid collection, or you want to label it blood. And then the liver and the diaphragm down here, and obviously the right kidney. So that looked okay for him. And it was as it happened. That this is actually his left upper quadrant. It was really hard to get it. But what I interpreted there and then was that this is the kidney. And this was meant to be the spleen around here. But there are 3 pockets of God knows what they are there around the spleen. And this was like literally the best image I could get within like 20 seconds that I had. And there, I'll tell you why later on. Bladder looked really fine. We just really understood that we have to actually put a catheter in him soon. And as I was going on and doing this, and the art line was inserted, my reg who put the art line says, "Oh, blood pressure is now 70/40." And bear in mind that we are already on pack B of our major hemorrhage protocol. So he's already had 4 of RBC and 4 FFP, followed by going into pack B now, and obviously the usual TXA and calcium. So, and this is his subcostal view, and which was really interesting because obviously this is a blunt trauma, and he doesn't have, apart from the 2 thoracostomies that we put in him, he did not have any evidence of any stabbing or anything. So as you can see, and you know better than me, there is a good area of hypoechoic, anechoic area around the heart. I'm really sorry that this Microsoft Teams is not playing the clip very well, but you could have seen the right RV is collapsing and there was a good inversion in the RA. What I did, which I do normally for my day-to-day practice, is I do modified eFAST, and what you could see was trying to get, I'm trying to get this, bear with me. Trying to get the apical 4-chamber view, you could see more of the RV collapsing as not actually dilating very well, and they could see the amount of the fluid around the heart. And again, talking about the modified eFAST, I quite like to get an IVC as well. And again, I do apologize if Teams is not showing this clear, but you can see that I know the patient, you can argue the patient is intubated, but there is the size of the IVC was 2.6 centimeters, and you can actually see the backflow of the blood as if like it's struggling to get into the heart. All right, so what's the diagnosis? I'm sure you recently we had a session about tamponade, and you know it again very well, that there is an area of hypoechoic or anechoic around the heart. Just a quick reminder that the more and the quicker it gets accumulated, the more tamponade. And the number I try to remember is always, if it's more than 2 centimeter pocket, is equivalent to a large amount of fluid, either blood or whatever in a cancer patient, for example. Right-sided collapse, obviously, to be very accurate, you want to talk about the diastolic inversion of right atrium and the collapse of the right ventricle, and which he pretty much had. And when it comes down to IVC views, you see the distended IVC, and the caveat is obviously always remember that if your patient is intubated, you have to interpret it with a pinch of salt. But actually, in this case, you could see the blood was going back, was struggling to get into the right atrium. All right. So what's the diagnosis? We said this. Forgot I added all this jiggly bit to my presentation. So let's just click on it. So what will you do now? Pericardiocentesis or resuscitative thoracotomy? How about the stuff in the belly? And now, while you're trying to think what you're going to do, although you're pouring blood into him, his BP reads about 60/35. This was a bit that I really would have enjoyed if it was a bit interactive. This, but unfortunately, given the circumstance, resuscitative thoracotomy. That's what we thought. Obviously, we need to do for him, but obviously there's argument about the pericardiocentesis. Does anyone want to say anything about this? Feel free to unmute yourself and tell me, because I'm actually eager to know.
I feel thoracotomy is a better option because that's obvious cause of shock here. Of course, this patient may have blood in the belly, which on the left side, because of splenic rupture or something. But the immediate cause of his shock probably is tamponade. So thoracotomy should be a good option.
Yeah, why won't you do the pericardiocentesis then?
So if he has myocardial rupture, then there's no point of doing a centesis. I mean, we need to stop the bleeding from the heart. So he probably needs some plugging and go to theater immediately.
Yes. So thank you for saying that. And on top of that, the other thing is that blood. So when a patient arrives, so this patient had he arrived to us at 11:30, 11:40. He had the incident at about 10:15, 10 o'clock when he was hit. And
the blood clotted already.
So yes, that's what I'm trying to say. So it takes you a good an hour. So when you fall off the edge of that cliff, no matter how much of a reserve you've got, so it might take you a couple of hours to get your blood pressure about 80 and maintain that and be able to actually give the clinician some time to work on you. But when you kind of go beyond the 70 and 60, and no matter what happens, the time that that blood is gonna clot, because the clotting factor is completely dead now, and basically you're putting a needle into a clot, which you can try a pericardiocentesis, but you're gonna end up doing a resuscitative thoracotomy. And the bit in the belly, obviously there was no free fluid. There was some possibility of something happening, but it didn't stop us from doing the thoracotomy, the two of us. And we immediately, which was a fascinating experience for myself, immediately with the clot removal, the BP is stabilized, and to a point that we actually stopped giving this guy any further blood or FFP or anything cryo. And then we kept him about 10 minutes. He didn't need any further anything whatsoever, and he maintained his blood pressure about 90 or 100 systolic, and to a point that we actually had time to go for CT. And the reason that we did that was obviously to find what's happening to his head, because we had no information whatsoever. And then the other thing was like, what's happening with that belly? The most interesting part of that evening for me, apart from doing a good thoracotomy, was the fact that although we took the patient to CT covered in blood, the radiologist came back and told us, "Oh, did you know that there is an open chest wall injury?" And we're like, "Yeah, that's us causing that." But anyway, the patient had the splenic laceration with hematomal collection and pancreatic injury. Thank you for mentioning that. That was a very good shout. And but there was no free fluid at all down in pelvis or anything else, anywhere else. Okay. And this was the measurement of, it was 2.6 centimeters and the biggest pocket. All right, I'm gonna rant a little bit now. Is tamponade a clinical diagnosis? Is ultrasound better than a 1935 paper written by Dr. Beck? This is not something that I want to tell people, just something that they need to think, and that if you shouldn't wait till patient's blood pressure is about 80 or 60 before you do something about the diagnosis of tamponade. And obviously that's where someone biased like me with ultrasound comes in and wants to echo everything and everyone to try and find out that they've got fluid around it and whether that's causing the RA and RV collapse and inversion. But this patient did not have a raised JVP. It's not something that's going to happen to all of your patients. And this patient was clinically in tamponade with a blood pressure of 60. At one point, actually, before cutting his sternum, he actually arrested for 30 seconds. Personal opinion and lessons learned. I personally think eFAST is massively helpful in the management of unwell trauma patients, and by unwell I mean code red. And I wouldn't personally do it on a patient who is completely stable, specifically in a place in my shop where you get it takes 15 minutes for you to get a CT, and sometimes less than that. And I do consider it in a patient that I really don't want to scan, for example, young patients who are stable, and I would do a frequent fast scans if I want to keep them. But again, the more I grow as a person, as a clinician, I kind of learn that because it's a very specific scan, it's not sensitive, it might actually lose its value in hemodynamically stable patients. You can completely disagree with me. But when I do it, I wouldn't do the eFAST protocol as designed by 2004 and the how-to that you can see it anywhere and everywhere. I do a modified eFAST, and by what I mean is when I'm looking at the heart, I will look at least in 2 views, not just 1 view, and I always add an IVC to it because it's important. It gives you further information, and then the lessons for us to learn, and we debriefed this patient debriefed about this patient, was the fact that what would have happened if we actually did not do eFAST, and believe me, even in my MTC, there is not many consultants who do ultrasound, or many juniors who are keen, and that's the whole point of us having these webinars and these talks and being the people who advocate the use of it, because obviously this patient would have had more blood and more blood and more blood, and then would have arrested, and then you wouldn't know what to do. You would have done a potentially blind thoracotomy, and would it have been too late to do that? Obviously, the whole point I'm trying to get in here is this, that to start with the question whether they can slow you down, and yes, depends on where you use it, but if you use it appropriately and you're trained well enough and you practice, you are using it properly, and you can it will help you to save a life. And this guy walks out of hospital 9 days later, although he was very unhappy that we saved his life because he wanted to die. And then I just want to go back on the first image just for fun. This image was actually from that I showed you as his right upper quadrant. It's not his right upper quadrant. It was another patient who was hemodynamically fully stable, and I just decided to do an ultrasound on him. Main reason was that he walked in, no one took him seriously, that he could potentially be unwell. He was young, he fell in the park playing with his kid onto his right side, and then he went to our minor injury unit, and then he had a chest X-ray which showed a small pneumothorax, and then I was like, okay, I'm just going to put a probe on him to see what's happening. And then you can probably, I don't know whether the quality of this would show this, but there is in here, there is a little small hypoechoic area of fluid. I have no idea with the quality of this presentation on Teams you can see it or not, but there is an area down there which is hypo. And then he actually, we ended up scanning him. He had a grade 3 renal laceration as well, and with a massive deranged kidney function. He did very well. So the reason I'm saying this is just because I get a lot. One of the kind of like the negativity that people tell me about doing ultrasound is the fact that many people go like, oh, how are you going to do a scan? You're going to find positive things in patients. Like, you need to scan more. The more you scan, you find positive things in people. And if you sit down and go like, oh, I'm not going to scan because it's very hard to see all the positive findings, you're not going to find them. So the more you scan, the more practice you get, you're going to find positive stuff. thank you. And this bit is not meant to be static, and as part of the thing that we did not cover in this eFAST presentation was that there's no lung sliding in this patient, and this patient had a pneumothorax. This is not static, but you don't see the lung sliding. Any big burning question?
There hasn't been any questions on the chat, but feel free just to unmute yourself and call out if you have any questions. Great. Well, thank you very much, Mehrad. Excellent presentation. Really interesting case. I think you make a great point about how sometimes ultrasound can just give you the confidence to act. So in this case, performing a thoracotomy, but equally, if it's a patient with a suspected PE and you're not sure whether to thrombolize them, just being able to get some ultrasound images to support what you already think can be enough just to give you that confidence to actually just go ahead. Or similarly with a pneumothorax, if you think clinically it's a tension pneumothorax, but being able just to check there's no lung sliding is just so useful. Yeah, giving you that confidence to act. Great. Just before we move on to the next presentation, I was wondering if everyone could just turn your videos on for a sec. I would love to see you all and see who's here, and maybe we could just have a quick chat and just see where everyone's from before we move on to the next half of the show. So we could do a little sort of circle time. So I'll call out your name and you can just tell us, just say hello and where you're from and anything else you'd like to add. So we have Dave Birrell. Hi, Dave.
Hello, can you hear me okay? Yeah.
Yeah. How are you doing, Wade?
So I'm very well, thank you. I'm from Scotland and I'm actually starting ST1. I'm an F4 just now, starting ST1 in Edinburgh in August. Part of the reason I was just actually looking up kind of PoCUS today because I'm currently in Rwanda just for a couple of months. I've been here before and just kind of doing a bit of life support teaching. I do kind of ALS instructing at home and stuff, and they essentially don't have access to much other than ultrasound, and they get loads of trauma from motos and stuff. So over the past little while, we've been just doing tons of kind of PoCUS exams and very variable quality and expertise amongst the team over here, but I have very little, so I was trying to learn a bit more, even just so I can follow along. Been pretty interesting.
Oh, fascinating. Yeah, if you want to stay behind after the meeting, we can send you some links and try and get you up to speed as much as possible.
Cool.
Yeah.
Yeah.
Very much.
Awesome.
Sivakami from St. George's as well. No. George Nardo, you probably all know, the godfather of PoCUS. Hi, George, how are you?
Steve, do you want to introduce yourself?
Hi, Mike.
He needs no introduction. If you don't know who George Nardo is, then you're living under a rock.
No. I was just asking Siva because Siva called me.
Oh, Siva, yeah. Yeah, are you there, Siva?
Yeah, I am. Sorry.
Hello, welcome. You're from George's as well. Work with Mehrad.
Yeah.
Welcome. And we have Gokul from the QE. Hey, Gokul. Thanks again for posting that excellent app on the Slack group, by the way. That's fantastic. I was checking out that the other day. Yes. Greg, is that our Greg from Tommy's? Possibly multitasking. And we have Kat Baird, one of our loyal followers. Hello again, Kat. How are you?
Hi, good evening. Yeah, I'm one of the team at the Royal London. I also work at Newham. I'm not very experienced in ultrasound, but I'm keen to get teaching wherever I can. So yeah, very loyal follower. Thank you for providing such high quality teaching for us.
No problem. Thanks for coming. Korushi, one of my colleagues from Tommy's. How are you, mate? Good to see you. And then we have Bainaz, also from Royal London. You're the ultrasound lead there, I believe. How are you? Oh, you're still muted.
Slow.
You're on mute now, Behnaz. You can.
Oh,
talk.
I know. Yeah, hello. Can you hear me now?
Yes, we can.
Hi, everyone. I'm Benaz. I'm one of the EM consultants at Royal London.
Great. Thanks for joining. And I think you're going to be giving a presentation the month after next.
July, yeah. Team
Yeah.
Royal London, yeah.
Yes, great. And we have Manpreet. Are you there, Manpreet?
Yes, hello, sorry.
No worries. How are you? Where are you from?
So I'm one of the registrars at Newham Hospital.
Newham.
Yes,
Ah, great. Welcome.
thank you.
And we have Matt from Lewisham, another loyal follower. Hey, Matt. And Mehrad, you've just heard from Mukhtar. So Dharmendra, is it?
Yes, yes. Hi. Hello to all. I'm one of the specialty doctors from Princess Royal Hospital, Telford. I moved from India about 6 months back.
Okay.
I've been doing bits of fast when I was in India. So here I mostly use it for IV access. But from that, I didn't use it much here. So
Okay. Well, welcome. Atul, we have from Tommy's, one of my colleagues. How are you, mate? And Trang as well, also from Tommy's. Hi, guys. Great. So next we'll move on to the second half of the presentation. So Ehsan Weidi, ST7, I believe.
No, 6.
Only 6? Okay.
Yeah, well, I think there was only 6.
Consultant.
Unless I take a couple of years extra to get there.
Most of consultants, so we're all headhunting him for jobs. I'm probably going to be battling George Nada to see which one of us gets him. Yeah, excellent. It was a pleasure working with last year when he was at Tommy's. So he's going to be talking to us about the role of PoCUS and pulmonary embolism. Thank you, Ehsan.
Thank you, Michael. I feel like I was I was punked by the Star Wars theme because Mehrad hasn't done it, so I'm gonna.
Oh yeah, I haven't said anything about Star Wars yet either. I'm sure you're all aware that given today is May the 4th, be with you, it is officially International Star Wars Day, and I'm a bit disappointed none of you are dressed as Ewoks or Stormtrooper as the invite did ask you to. But anyway, Ehsan's got a bit of a Star Wars theme going on, and there'll be a little quiz at the end of tonight as well, which will also have a few Star Wars questions thrown in there. Thanks, thanks, mate.
Yeah, can you see my screen's okay? Is it? Can you see it?
Yep. It's looking good.
That one. Yeah. Okay. Well, let's start from the beginning. All right. So I'm just going to do a talk about PE, and we'll be looking at some other ultrasound. It'll be quite a. I'll start off with some basic views for echo. I know there's a different mix of levels amongst us, so it'll have a mix of things in there hopefully that will suit everyone. But I'll start with some basic echo views and a basic assessment. I'll look a little bit into scanning for DVT. Then I'll talk about a case that I saw, which I thought was quite interesting. We'll then do a little quiz on echo findings in PE, and I'll talk specifically about TAPSE and 60/60 rule. And then lastly, just a little bit about lung ultrasound and triple PoCUS. So for echo views, so we're using the phased array probe. And we get the 4 main views we get in kind of emergency PoCUS would be the parasternal long axis, the short axis, the subxiphoid, and the apical views. And parasternal will be taken just left of the sternum with a pointer towards the right shoulder. The parasternal short axis with the pointer towards the left shoulder, so you rotate from the parasternal long axis to the short axis about 90 degrees. Subxiphoid view is taken in the xiphosternum, and then the apical view just lateral to the midclavicular line, just over the apex B. Just on assessment of the echo views, so we use kind of a DEFG format. It's one of the ways of doing a quick assessment. So the D stands for dimensions. And it's kind of four main measurements for dimensions that you do in the parasternal long axis view. So the first measurement you'll be taking is the right ventricle, and it should be no more than 3 centimeters in diastole. The aortic root is next, and that should be no more than 4 centimeters in systole. And then we move on to measure the left atrium, which should be no more than 5 centimeters in diastole. And then the left ventricle, which should be no more than 6 centimeters in diastole. Then we assess for effort. So we're looking at kind of left ventricular function. And that would be, you can do that in the parasternal long axis, and you kind of imagine the finger in the ventricle, and you want to see all the walls contracting towards the finger, and you want to make sure that there's kind of contractility about 1/3 to ensure kind of, well, to indicate left ventricular function or good left ventricular function. Then we move on to assess for fluid, and you're looking for pericardial fluid, which you can see here in the image, which is kind of tucking in just anterior to the descending aorta here. And you can also see pleural fluid in these views, and that will not be going anterior to the descending aorta. And lastly, we just look for gradient. So well, the last one is G for gradient. So you're looking for turbulent flow, and we use color Doppler here, and you're looking for turbulent flow from, well, indicating tricuspid regurgitation, aortic regurgitation, or aortic stenosis. For DVT scanning, it's a pretty simple scan to do. There's quite a few different protocols. There's quite a few different protocols that can be used. So there's a 2-point scanning method. So you use the linear probe, looking at the veins in transverse and applying pressure to see if the vein is collapsible. The 2-point scan, you're looking at the saphenofemoral junction just up here, and you compress to see if the vein is collapsible, and the popliteal vein in the popliteal fossa. So just posterior, kind of at the back of the knee, applying pressure to see if the vein is collapsible. For 3-point scanning, you include the deep femoral vein, and you can move on to an extended scan, which is scanning the entire length from the inguinal ligament down to the popliteal fossa in 2-centimeter increments. And you can also do a whole leg scan, which kind of looks at the calf veins as well. In ED, I often just use the 2-point scanning, so looking at the saphenofemoral junction and the popliteal vein. It's quicker, it's easy to do, and relatively good yield. So just looking at the saphenofemoral junction, so what you should see is the femoral vein, the femoral artery, and the saphenous vein. And when you apply pressure, so the view you get would be kind of like a Mickey Mouse view here. So you've got the face and the 2 ears. And at the popliteal vein, you can see here the popliteal vein and the popliteal artery, sorry, at the popliteal fossa. And the picture to the right is the same view with compression, and you can see the vein has disappeared. So that would indicate a patent vein. So just onto the interesting case that I saw. So there's a 43-year-old lady who came in with a 3-day history of a cough and shortness of breath on the day of her presentation. She had been recently diagnosed with motor neuron disease and had reported some reduced mobility over the last 3 months because of it, but no kind of significant periods of being bedridden or anything like that. And otherwise, she was fit and well, no other medical problems, and no regular medication. She was blue lit into A&E with a heart rate of 140 beats per minute. She was hypotensive at 89 over 42 and had an oxygen requirement with SATs of 96 on 10 liters. And with a low-grade fever, or kind of a temperature of 37.8. On examination, she was tachypneic with increased work of breathing, auscultation of her chest found clear lung fields. She was peripherally shut down with cool peripheries and a thready radial pulse. But examination of the rest of the systems were normal, and her cars were soft and non-tender. So quite a basic question here, just a differential diagnosis, but I just wanted to start the little quiz we have online. So if you guys have a phone, if you can just go to menti.com and type this code in, and then just put in what you guys think for differentials. And let me know if there's any problems logging onto anything there. Yep, so we've got PE on there. Any other differentials? I think I split the differentials for PE with the title or the topic that we're covering, but Lightsaber, yeah, could be a traumatic lightsaber injury. Yeah, PE, COVID. Yeah, obstructive shock. Chest sepsis, yeah. Yeah, so essentially we thought this could very well be a pulmonary embolus. We were also concerned about possibility of septic shock, and yet COVID-19 can't really get away from it. So we gave a high flow oxygen, we gained IV access, sent bloods and blood cultures, and took an ABG. We gave her a fluid bolus of 500 mils of Hartmann's to see if that would help with her blood pressure. And we gave her some IV Coamoxiclav and requested a chest X-ray. So this is her arterial blood gas on 15 liters. So, her PaO2 is quite high, but but she was on 15 liters and she was still significantly hypoxic. So she had an AA gradient of about 50 on this, calculating it from that. Portable chest X-ray showed clear lung fields. So at this point, we went on to do a point of care ultrasound. Oh, guys, I'm very sorry. I think there's someone that keeps ringing at the door. Can you guys excuse me for 1 second just to buzz them in? I'm not sure.
Yeah, no worries, Ehsan. That's cool. So I guess in a hypoxic patient with a clear chest, obviously we would all be thinking about a PE, but would any of you have the balls to actually act on it without any further confirmation? Thanks, mate. Just
sorry about that, guys.
For you.
Thank you. So I've got some echo views up here from the point of care ultrasound. So if you guys are still logged on, we'll go on to the next slide on the Mentimeter. Michael, how do I click this next?
Just press the right arrow. It should go onto the next.
Oh yeah, here we go. Okay. So, oh, that's not the view I was looking for.
And then people on their phones just press go to next slide and it will go to the next question.
So Michael, it hasn't actually come up on this one, I'm sorry. So I'll go into the views and then just get people to maybe say what they see from the views. So the parasternal long axis view is here. And we've got the parasternal short axis as well. The views aren't great, but I've got some video clips that I can run through. Oh, that's a question. Oh, yeah. Any thoughts on those views, guys? Anything that people can see on those? Oh, guys, I'm very sorry. Someone's knocking on the door again. I don't actually know.
Take over for a sec. Yeah, would anyone like to comment? Feel free to jump in.
Right ventricle size on parasternal short axis, maybe.
Yep. RV looks dilated on the parasternal short axis. Yep. Cool.
Sorry about that, guys.
Is it the debt collectors?
Yeah. So I can just go onto the videos and just show you there. So this is the parasternal long axis here. So yeah, the right ventricle, I heard you guys were saying is quite dilated in that view. And then we've got the. Any thoughts on the parasternal short axis, guys? So the right ventricle,
obviously, right ventricle is dilated.
Yeah.
And it's pushing the left ventricle, and we have D-shaped septum.
Yeah.
So all this means is there's right ventricular pressure, probably because of pulmonary embolism in this patient. So yeah.
Yeah, so you've got some bowing of the left ventricle there with quite a dilated right ventricle. And then this view, again, quite a dilated right ventricle. So the free wall was quite hypokinetic. It's not very clear in that image, but if you look at the apex, it's still, contracting relatively well. Does anyone know what sign that is?
McConnell sign.
McConnell sign.
It's not McConnell sign.
Yeah. So just going on to the DVT scan of the veins. So the saphenofemoral junction was collapsible, so there's no signs of any obstruction there. In the left popliteal vein, you can see again quite good collapsible veins on the left, and on the right here. So not was not collapsing the vein. You can see here's not collapsing, and you've got the artery even collapsing there below it with the amount of pressure that I'm placing. And actually, you can see the thrombus in there as well, just here in the view. So yeah, what would people do at this stage? Would they thrombolize based off of that, or her blood pressure didn't really pick up? It was still about 89, 90 systolic.
Yeah, I think
If it's ARS, I would.
she's sorry. If you're diagnosing her as an obstructive shock at this moment, and the only treatment for that would be to reduce the clot burden, so it would be like a discussion for half dose or full dose thrombolysis with the risk of bleeding and other things considered.
Yeah, so we essentially prepared for thrombolysis. We informed the critical care team, who came down quite quickly. Actually, they were available to review the patient, and they wanted to. They were a bit concerned about thrombolizing and felt they would prefer to thrombolyze her in ITU, and so they were happy to escort her to the CT scan, which was adjacent to the department, and we did a CT, which showed a saddle embolus with clot extending into the pulmonary arteries. So she went up to ITU, was thrombolized, and was anticoagulated, and was stepped down about a week later. So just putting out another question to the group, apart from including the right ventricle dilatation and things we've mentioned, what are the signs that people are aware of in echo for PE? So if you go onto the Mentimeter again, you can just type it in and see what, and it will just come up on the screen. We can discuss it. I've got about 10 or 11 signs. Oh, no. Oh, they all just jumped in at once. So yeah, we've got McConnell's sign, early systolic notching.
So if you switch, do you want to switch tabs to the Menti,
yes.
so we can see the word cloud?
How do we do this? Stop sharing. I can share tray.
I'll keep sharing, but just flip over to the browser tab. Yeah, exactly.
Oh, did you get it?
That was it. It was there just for a sec.
There we go.
Yeah.
Yeah, so visible clot, great. Oh, it's growing. Plethoric IVC, McConnell sign, 60-60 sign, decreased TAPSI. Yeah, so tricuspid regurgitation jet and high right systolic ventricular pressure. Yeah, great, we're getting quite a few. The D sign, yep. What else we've got? Decreased TAPSI. Visible clot seems to be the biggest one so far, the most people have said. So if I swap my screen over again. Yeah, so we've said, so pulmonary hypertension, ventricular size ratio, so a ratio greater than 0.6 to 0.1 between the RV and LV, right ventricular hypokinesis, and then McConnell sign is the sparing of the apex with right ventricular hypokinesis, right ventricular end diastolic diameter, abnormal septal wall motion, tricuspid regurgitation, which we said, great, right heart thrombus, ventricular systolic pressure, TAPSI, and 60-60 sign. Great. So how useful is right ventricular dilatation in PE? So Dresden et al. Looked at 146 patients, 30 of which had a PE. And these were patients who were short of breath, had high Wells and D-dimer. And they defined right ventricular dilatation as a right ventricular to left ventricular ratio greater than 1. They found that the echo had a sensitivity of about 50% and a specificity of 98% in PE. And a meta-analysis by Fields et al. Kind of reported that right heart strain had a sensitivity of about 53% and a sensitivity of 53% and a specificity of 83%. So just going on to some more of the some more kind of slightly more technical ways of assessing for right heart function. So TAPSE is a tricuspid annular plane systolic excursion. It's a measure of kind of right ventricular contraction and has been validated for kind of global right ventricular function. So how do we measure TAPSE? So it's an apical 4-chamber view, and in M mode, you align the M mode cursor through the apex and into the junction between the right ventricular wall and the tricuspid valve, and you're measuring displacement through that. So what you get is, as the right ventricle contracts, you get movement of the annulus across that plane, and it forms a on the spectral Doppler will show a waveform, and you measure the distance between the peak and the trough. So anything less than 17 millimeters is abnormal, and studies have shown that a TAPSE less than 17% in PE has a mortality rate, well, increases mortality by about over 4 times. The issue with TAPSE is that it's angle dependent, and it's quite easy to underestimate the Doppler signal if it's not parallel to the annulus. So how do we assess whether the right ventricular failure is acute or chronic? So there's quite a few other conditions that can cause right ventricular dilatation or kind of RV dysfunction, things like COPD, myocardial infarction, pulmonary hypertension. In this patient, she was, had no other cardiac or respiratory conditions. So, we could assume that it's most likely that her right ventricular dilatation was acute. But in order to tell between acute and chronic in your kind of comorbid patients, we can use a 60-60 sign. And so it's a tool that's used to determine whether the right ventricular dysfunction is acute or chronic. And a positive sign is a right ventricular pressure that is less than 60 millimeters of mercury, and a pulmonary acceleration time less than 60 milliseconds. So that's the 60-60 comes from. So it can only be used in patients who have got right heart strain, because a normal fit young person without any cardiac issues will have a positive 60-60 sign. So you can only use it in combination with someone who has right heart strain or signs of right heart strain. So how do we measure it? So it's again taken in an apical 4-chamber view. You identify a tricuspid jet using color Doppler flow, and then you pass the continuous Doppler wave through the regurgitant jet, and you measure the velocity of the regurgitation. That is then used, using the Bernoulli equation, you then calculate the tricuspid gradient, which is 4 times the maximum tricuspid regurgitation squared, and you basically add that to the right atrial pressure. And the right atrial pressure is assessed using the IVC, and it's an estimation. So you assess for collapsibility. If it's less than 50% collapsible, then you're assuming a right atrial pressure of 15 millimeters of mercury. If it's around 50% collapsible, then you're assuming around 8 millimeters of mercury. And if it's more than 50%, then you assume 3 millimeters of mercury. So you calculate those two, you combine them, and if it's less than 60, then it suggests that it's an acute right ventricular dysfunction. You also then assess for pulmonary acceleration time, so that's the peak acceleration time. So that would be, you take the view in the parasternal short axis, and you fan up towards the aortic valve. You pass the pulse wave through the pulmonary valve, and then you assess the time taken to peak velocity. And if that's less than 60 milliseconds, then that will also suggest it's an acute right heart failure. So the issue with the right ventricular dilatation is, is it sensitive enough? So echo alone, I mean, the sensitivities were about 50%. So, is that really enough for us to kind of make clinical decisions on alone? So Naziri et al. Looked at triple PoCUS. They got 357 patients with dyspnea, 110 of those with who ended up having a PE. So these were patients with well scores more than 4 and a positive D dimer. And they carried out 3 system ultrasound. So they did a lung ultrasound, which looked for subpleural infarcts. They did an echo looking for just right ventricular dilatation, and they did a DVT scan. They found that lung ultrasound had a sensitivity of about 60.9% in PE, with a specificity of 95%. And echo had a sensitivity of only about 32.7%, and a specificity of 90. And DVT had a sensitivity of about 52%, but a much higher specificity of about 97.6%. When combined, however, if patients had one of those on a triple scan, they found that multi-organ sensitivity was about 90%, with a specificity of 86.2, which is, you know, pretty decent. Just for any of you guys who may not be that familiar with lung scanning, I'm sure now in COVID most of us are, use the linear probe in a lawnmower technique, fanning across the intercostal spaces anteriorly, posteriorly, and laterally. And subpleural infarcts are small, hypoechoic lesions more than 0.5 centimeters. So just out to the group as a little discussion, I mean, what do people feel about the role of PoCUS in diagnosing PE in the ED? Have people used it to identify PEs before? How do they feel about the sensitivity and specificity? Would they use it? What do you guys reckon?
Yeah, feel free to just unmute yourself and shout out an answer.
Mike, Ehsan, can I say something? Because this was my CTR. I still argue it is very, very important to use the ultrasound, to use the echo for even in a stable patient, in a patient who will go for a CTPA, because if you find that there is a right ventricular dilatation in patient with a PE, the mortality within 28 days or out of hospital is very, very high. So you could say this is a very high risk patient. He had a PE, he's stable. Admitting the speciality, you're gonna admit him to a usual ward, but it's unlikely that he will survive out of hospital if you find that the right ventricle and the troponin is high. In a patient who is PE, that it is confirmed on a CTPA. So I still argue that our role as an ED physician, still we have, in the middle of the night, there is no cardiology, for example, in a DGH that will perform an echo, but it is your responsibility that you go to the medical region, tell him, I find that this patient whom I have done for him a CTPA and confirmed PE, he got a right ventricular dilatation, and so he needs an HDU, or he needs to be monitored very, very carefully. If this patient is not a patient that he will benefit from outpatient treatment or giving him some Clexane and send him home because he had a CTPA confirmed. No, this patient, the likelihood that he will not survive out of hospital. This is what is the messages that we should be delivering. So it is very, very important.
Yeah, thank you. Yeah, it's really...
Thanks, George. Yeah, absolutely agree. And I think it's a really good point. Often just identifying RV dilation by itself is all you actually need, especially if it's a young patient who doesn't have any lung disease. You don't need to be able to do any fancy technical measurements of Doppler or TAPSE. Like if it's a young person, there's a dilated RV and it's a good story for a PE, then that's already all the information you need. So yeah, thanks very much, George. Did you have any more slides, Ehsan?
So yeah, this is the last one. So just mention the last thing from Nazir et al. Was in their scanning, in their study, they found that 132 of their patients who had negative point of care ultrasound and an alternative diagnosis, none of them actually had a PE. So the kind of things they picked up were pneumonias and pleural effusions, and 63 of those patients they found in their study had a DVT who were going to be anticoagulated anyway. So actually what they found is that there's a possibility of kind of a reduction in CTPA use of about 50%. So just in terms of the role of point of care ultrasound, that, you know, potentially in the future could be quite useful. But I think a lot more study needs to be done in it. And for me, I think, you know, the point of care ultrasound in an unstable patient definitely gave me more of a confidence in kind of thrombolizing that patient. But I think as Dr. Nada was saying, actually, if patients have got signs of right ventricular dilatation, then maybe the outpatient management is not going to be appropriate. So yeah, thank you, Dr. Nada, for that. And that's about it, actually. Is there any questions?
Thank you, Ehsan. Excellent presentation. Any questions from anyone? Feel free just to shout out.
I just wanted to add everything as Ehsan and George said. To confirm, again, obviously, as my disclaimer, I'm quite biased, but we in my department, we are, funny enough, because George mentioned the DGHs and the lack of access to cardiologists. In my department, we are extremely thrombolyze friendly, and so yeah, if you've ever had a PE in your life, you get thrombolysis by us in our resus, and which is very interesting. So because our respiratory physicians are quite pro thrombolysis, and I can tell you, like, in the last year at least, I've thrombolized a good 8 people, and but it's very interesting in a sense that I once had a patient who came with abdominal pain and it was in shock, very similar, all the images are completely the same as your patient, Ehsan, but it was there was no clear history. She was completely mottled, and initial thoughts were this is a septic shock, because she was like, literally the only thing that she could say as part of her history was, am I going to die, right? I'm going to die, I'm going to die. And basically it was just the views of the heart that just literally showed everything that you just showed, Ehsan. And it was the moment that, okay, am I going to thrombolize this patient or not? And actually, so what I've learned from reading the literature is the fact that the definition between the massive and submassive PE. So there's that 15 minutes golden time that people mention, that if you try and give a bolus to a patient and your blood pressure maintains, so you have got potentially a submassive PE because your blood pressure picks up above 90. So that's what I did for this patient, but and that's actually happened really. So the lady had the 500 fluid, and the blood pressure remained about 90 for about 5-10 minutes. So I was like, okay, so I'm gonna go to CT, and but she didn't look very well. So I actually went to CT with autoplays in my pocket, and as we lied her flat, bang in the middle of the CT, she arrested, and so we literally, like, we didn't have the CT so done, so we literally thrombolized her on the CT table with 50 milligrams stat, and then we got her back. But it made me think, as you just said, Ehsan, whether you thrombolize a patient without a confirmatory CTPA or not. And people are going to be biased with their experience that they've had, if next time I see a patient like that, if they look unwell, even though their blood pressure is 90 because I just gave them or 100 systolic because I just gave them 500 of fluid, wouldn't I thrombolize a patient? I probably would next time if someone looked that unwell, and I can see all of these findings. And funny enough, the patient was brought in as sepsis with right upper quadrant pain, and it was the fact that she was she had the right lower chest pain because she was infarct in her lung.
Yeah, I think the issue for me is that we all know that if they're hypertensive, they've got signs of, they've got a high enough score, you thrombolize them, and if you don't have another source for it, the issue is that it's just having that. I don't do it very often, and I don't know if other people do, but I think it's just that extra bit of confidence to say, well, actually, I've got quite good signs on this, on the echo or on the ultrasound, and actually just giving you that extra confidence to do it, because we rely so much on CT now that people, I think are a bit hesitant. And actually, as the ITU team were, they prefer to take her to CT scan, though she was hypotensive, and thrombolize her on ITU rather than do it in ED. And I just think, if other places don't have those kind of facilities, it really limits what you can do.
Yeah, I think Gokul wants to mention something. Go ahead.
Yeah.
Yeah, and just wanted to mention something similar on lines of submassive PEs, where if I could just share an experience where I had a young 20-year-old who was brought in with a history of syncope, just brought in from triage she was not blue lighted, she came in walking, and then she syncoped. And we were initially, I think we were called in to just do a fast scan. Maybe she's pregnant, maybe she has having an ectopic, and just eventually went around. I kind of found similar D sign, right heart hypokinesia. So we had a diagnosis that, oh, most likely this might be a PE. Although her blood pressures were fine, she was tachycardic, she was slightly short of breath, but she was hemodynamically on the borderline of being stable. But we've seen some kind of some pathophysiology suggesting a big clot burden or a possible submassive PE. So even before we have any of the blood test results, we kind of know, and this is during the night, so we know that she would be an ideal candidate for possible thrombolysis, or if she worsens and she goes into peri-arrest, then we should be ready for it. But obviously, during my night shift with this patient, it was a big discussion. So it was easy for me to arrange for a CTPA overnight, so that at least the bedside PoCUS kind of helped me to get that, to prove that there is a big clot burden. But also with such patients who are young, who have right heart strain, who possibly we sometimes don't have a pathway for submassive PE where we work. So we either thrombolize for a massive PE or in a cardiac arrest, or we just don't thrombolize and we just anticoagulate and admit them. If we are too worried, we probably go to an extent of getting a CTPA under the ED team, or otherwise it's just managed by the medical team. But with this patient, it was like a discussion saying that I'm worried that she's got a big clot burden, she might benefit from thrombolysis. Eventually, the decision was made by the medical team not to do it. But funny enough, 2 days later, she maintained a blood pressure of 90 or 100, and then eventually she was thrombolized. But you could argue that these findings are at the doorstep. When you can also say that even if she did make it with anticoagulation, 30 days or 40 days post, or 2 to 3 months post this episode, she will have so much pulmonary hypertension that she might not be able to walk or do the same kind of activity, because she's already had a huge strain on the right ventricle. So I think looking at PoCUS at this bedside eventually can give you, you can kind of tell what's to happen acutely as well as in the long run. So I think if we can focus, I'm not sure if other places have, like you said, you're very pro thrombolysis. Maybe that's good for your setup, but for our setup, I think we need to, where I work, we need to probably have that kind of a discussion with other teams that, okay, if we find right heart strain and it's a submassive PE, then we should thrombolize or not thrombolize. It probably helps with that decision making, I guess.
Thanks very much, Gokul, for sharing that case. Any other questions from anyone? Yeah, I guess just to wrap things up, I think the way I think about PoCUS in PE is, like, if it's a young, healthy patient and they don't have any lung disease, then if you see RV dilation, that's pretty specific for a PE in the right context. Also, as we know from that Nazarian paper that Ehsan talked about, the presence of a DVT is very specific for a PE, almost 98% specific. So if you see a DVT, that's pretty much a slam dunk. So it's really only in the group where it's like an older person who maybe could have some chronic lung disease and could have chronic pulmonary hypertension and chronic RV dilation. In that group, it's if you don't see a DVT, then it's a bit more technical, and then that's when some of the other echo markers can be useful. But yeah, for a lot of the cases, just the presence of RV dilation by itself will be enough. So don't be too put off by some of the those other technical stuff that we were talking about. Okay, so next I have a little quiz prepared. So it's mostly ultrasound. There's a little bit of Star Wars in it, but not too much, don't worry. So if you grab your phones again and go, it should be on the same Menti that you were just on already. And now it's a competitive quiz. So you get points for getting the correct answer, but also for how quickly you answer. So fingers on buzzers, and you can put your name in as well, so we know who the winner is at the end. So I'll wait for you all to log in. There's about 10 questions, or 11 questions. Less than half of them are Star Wars, so if you're not a Star Wars fan, don't worry. Okay, does anyone need any help logging in? I think we've got about 5 or 6 of you so far. Okay, well, hopefully the rest of you will be able to catch up. So we'll start with question 1. So remember, the quicker you answer, the more points you get. So within the left upper quadrant, where is free fluid most likely to collect? So there has been some research on this topic. And the code is at the top of the screen there. So that 8-digit code at the top of the screen. Okay, so the correct answer there is spleno-diaphragmatic, between the spleen and the diaphragm. So in the right upper quadrant, free fluid is most likely to collect around the inferior lip of the liver, and it's pretty rare for it to accumulate between the liver and the diaphragm. However, on the left, it actually is more likely to accumulate between the spleen and the diaphragm. So make sure when you're fanning through that area that you slide up sufficiently and get that view just under the diaphragm, as well as all the way down to the inferior pole of the kidney. Okay, so let's see who is winning so far. Hopefully the rest of you will be able to log in shortly. Here's the code at the top of the screen there, that 8-digit code. Well done, Behnaz. Okay, so question 2. I think this may be a Star Wars question coming up. Ah, yes, it is. So on what planet does this battle occur? Alderaan, Hoth, Naboo, or Tatooine? This is from The Empire Strikes Back. Apologies if anyone's from Gen Y or Gen Z. Oh, no one. Oh, I'm very disappointed. That is the ice planet of Hoth. I'm showing my age. Okay, let's see. We've got a few more people logged in now. Nobody got that one. Okay, you'll have a chance to redeem yourself later on with some more Star Wars questions. Okay, so question 3. 60-year-old male with chronic liver disease falls down a flight of stairs. He's hypotensive. What does the image show? Remember, quick answers get more points. So ascites, blood, free fluid, or are those toes? Okay, so all ultrasound tells us if you see something black or anechoic in the peritoneal space, all you can say is that that is free fluid. So in this context, someone with chronic liver disease, it could be ascites, but he's also had trauma, so it could be blood. So all you can say is that it is free fluid. Okay, let's see how the leaderboard is looking now. Oh, Behnaz doing very well. But Gokul is also within striking distance. And Matt, well done. Okay, question 4. What rank is this rebel fighter? Is he a lieutenant, captain, commander, or an admiral? And if you don't remember, a clue is his catchphrase is, "It's a trap." So that is Admiral Akbar, I'll have you know. So that's, I think we've got maybe a non-Star Wars friendly audience, but he's a very famous, important character in the Star Wars trilogy. Well done, Lola. Okay, so the next question, back to ultrasound. So a RTC patient intubated on scene for agitation, on arrival to ED, drops his SATs to 60, and this is the image. So what will you do next? Check the tube, thoracostomy, a quick chest X-ray, or finish your eFAST exam? Great, yes, thoracostomy is the correct answer. So you could just see a little bit of lung sliding on the left. So that's called the lung point, where you see the transition point between sliding and no sliding. So that's very specific for a pneumothorax. So yeah, based on that, given he's obviously severely compromised, you would go ahead and do a thoracostomy. Okay, so a check of the leaderboard. Okay, well done, Gokul and Greg. Catching up to Benaz. Pretty tight at the top there. Okay, so next question, halfway through. Who wields a double-ended lightsaber? So who is that? Is that Darth Vader, Darth Sidious, Darth Maul, or Count Dooku? So this is from the more recent Star Wars films. So hopefully some of you may have seen that. So well done. That is Darth Maul. And yeah, I don't know if any of you guys have used the GE V-Scan, the one with the double-ended probe. It's got like a linear array on one end and a phased array on the other end. It always makes me think of Darth Maul, that probe. So let's have a look at the leaderboard. Who are the Star Wars fans? Darth Vader. Ehsan's joined in late, but he's making a late charge for it. Darth Vader, well done. Okay, question 7. We're back to ultrasound again here. 70-year-old with COPD, acute TIB and wheeze, tachycardic, a bit hypotensive but alert. That's the echo clip. What is your next move? CTPA or thrombolize? Okay, so the answer we're looking for there is CTPA. So I was trying to paint a picture of someone who may well have chronic RV dilation, given he's elderly and has lung disease. And also, even though he's a bit hypotensive, he's not really peri-arrest. He's alert. So in this case, you would really try and get a CTPA first to confirm whether it could be a PE before going ahead and thrombolizing, because in this age group, the risk of intracranial hemorrhage is much higher. Okay, let's have a look at the leaderboard again. Well, Darth Vader is making a late surge. It's very tight at the top there. Still could go any way. Okay, 3 questions to go. Question 8. So according to Nazarian, 2014, which of the following is most specific for diagnosing acute PE? So the lung findings of the little infarcts, echo findings, or the presence of a DVT? Which was the most specific? So it was actually DVT. So DVT was almost 98% specific for a PE. Lung findings were also quite specific, I think 95, echo a little bit less. But yeah, the presence of a DVT is really a slam dunk. If you see that in someone with a good story for a PE, that pretty much rules in the diagnosis. Okay, so Kathy and Matt making a late charge, just within striking distance. Okay, so a couple of questions to go. Okay, so now a bit of a change of tack. We're doing a bit of IV cannulation. So what proportion of a cannula must be within the vein for it to reliably knot tissue? So that's a picture of what happens if it does tissue and you get extravasation necrosis. So there was actually a study on this topic, so it is a known fact. Oh, excellent, yeah. So it's actually 2/3. So we know that 2/3 of a cannula must be in the vein for it not to tissue. And so, okay, well done, Kathy and Gokul. So given that we know that, this next question is a fiendishly difficult trigonometry question. So I've given you an extra 5 seconds. So if your vein is a centimeter deep and your trajectory is 45 degrees, what length cannula would you need to ensure that 2/3 of your cannula is in the vein? It's just simple trigonometry. Okay, so the correct answer there is 4.2 centimeters. So where I work, the standard cannulas are about 3 centimeters long. So if you're going for an ultrasound guided cannula and your vein is a centimeter or so deep, then you're going to need a special longer cannula. Okay, and then the final question. Have a quick check of the leaderboard before the last question. So Kathy is ahead, and S and Gokul are both within striking range. So it's between Kathy S and Gokul for the last question, which I'm afraid is another Star Wars question. What was Chewbacca's weapon of choice? Was it the Holy Hand Grenade, Phantom Torpedo, Lightsaber, or crossbow? Chewbacca being, of course, the most famous of the Wookiee species. So Chewbacca's weapon of choice was the crossbow. Excellent. Let's see who the winner is. So Gokul and Kathy both got that one right, but Kathy was quicker. And so Kathy has won the quiz. Would you like to say a few words, Kathy? Is that cat bed?
Funnily enough, that's me. It's my evening name. No, I think it just gave me some alias in case I got them all wrong. So it was a great surprise.
Well done. Not many people can say they won a Star Wars PoCUS quiz in Rwanda. So you can add that to your CV.
Perfect.
Okay, well, thanks very much to our speakers, Mehrad and Ehsan. Thanks everyone very much for joining. Stay tuned for the next session on the Slack group where we'll post it next month. And yeah, if you want to stay on the line, Dave, we can have a little chat. Does anyone have anything else to add? Ehsan, Mehrad?
No, thank you.
Great.
Just thank you very much for tolerating me.
Cool. Okay. Thanks very much, guys. May the 4th be with you.
I'm stopping recording.